I am Brian Sims. I'm Senior Medical Advisor with NASPID, and I am thrilled to be your host again today for this Crisis Jam, which comes after a huge response that we had last week that we'll mention. Um, on this first slide, though, I just wanted to kind of point out to everyone, this is from the Colorado Crisis Services, and this quote comes out, "My farm was underwater and I was drowning." And it's really one of those perfect segues into what we're going to be talking about today. Because within that, the Colorado Crisis Service, Colorado itself was responsible for inspiring those three statements that we have seen on the backs of the t-shirts: someone to call, somewhere to go, someone to respond. All of those things came out of the efforts and the foresight and insight that a lot of the states, including Colorado, has been a part of. So we're really excited about what we will have later on as a presentation. So let's go ahead with the next slide, please. Now, this is kind of a new slide for everyone. The left side of it, you'll see the listings of all the national organizations, which is the slide that you always have seen in the past. But we kind of modified the right side so that you have the opportunity to be able to see the phenomenally increased amount of participation that has come in. And we've listed the top 4 Crisis Jam community meetings. And if you'll notice, we split it into YouTube and Zoom so that you can see the various numbers from those who were connecting by Zoom or connecting by YouTube. And you'll see in February a total of 489. But last week, with the Assistant Secretary on board and the 23 other speakers that took place in that short time of an hour, we had a total of 606 individuals online. So this is really a testimony to, number one, the efforts that have gone into it, and most of all, the interest that has been seen in this learning community and this connection with 988. Next slide, please. This is a reminder again about the talk.crisisnow.com site. This is a wealth of information for anyone. You go into the site, you're able to pull information going forward as well as backwards. If you want to take a look at some of the videos from the past Crisis Jams, you'll find it here. You also will see the link on board so that you can connect with each of these times. So it's again a reminder that some of the best information, in case you happen to miss maybe 1 or 2 of the sessions, you'll have an opportunity to go back and take a look at it going forward. And next slide, please. Okay. We have the next one, please. Okay, at this point, many of you have heard already about the passing of Sharon Jenkins Tucker, and I wanted to ask at this time if we could bring on Wendy Tigring to speak a little bit on this. And thanks, Wendy, for doing this.
Sure, Dr. Sims. I'm so glad to be here with all of you today. I'm so sorry that I'm having to be the bearer of news if you've not heard this, but certainly I know many of you have. Sherry Jenkins Tucker used the phrase often, "I am the evidence," and so I have down here, you know, the evidence, because her life really evidence of recovery. Sherry was the executive director of the Georgia Mental Health Consumer Network, and in that role, she directed the certification of all of the certified peer specialists in Georgia for adult mental health. Under her leadership, right, the work we're talking about, she developed the peer wellness and respite centers where you know, thousands of individuals have had the opportunity to have had kind of warm living room-like support, either in the day for drop-in or in the evening for drop-in. She developed the product with our state agency for the warm lines, for the peer run warm lines, the peer answered warm lines. For those of you who've not been around as long as I have, or as long as Sherry has been, together, she assisted NASPID and Samsa and DVHDD with the initiation of what was called the Pillars of Peer Support series. It was multiple years, and the first states that implemented peer support, she pulled together with the Carter Center in Georgia us naming what were the kind of the emerging core competencies related to peer specialists nationally. And so those became kind of the foundation of what finally emerged as the Samsa core competencies. She hosted and consulted with half or more states in this union, and countries all over the world came to Georgia to spend some time at the Georgia Mental Health Consumer Network conferences to talk about lived experience, recovery, the role of certified peer specialists, and what could be done. And those countries have implemented peer support. And so what a testament and legacy. She was a published author. She worked with the VA in establishing the peer program, and we invited the first peer specialists from the Veterans Administration to walk through that program with us. She served as leadership on the Southeast MHTTCs. She won the Clifford de Beers Award. She created the curriculum through a TTI grant with NASHVID for what became the foundation for the Whole Health Action Management work, WHAM, and then worked, side by side again with me on developing the Whole Health certification for peers in Georgia, as well as the service definitions for whole health, doing all the coaching we did for our provider network and the like. So I could go on and on, but let me say, champion, ally, friend, nudger, poker, because she would keep our system moving. And what a honor it has been in my life to work with her. And I just want to say thank you, and thank you for showing us the evidence, Sherry, and being the evidence.
And thank you, Wendy, for sharing that. And certainly our condolences go out to Sharon and her entire family. Thank you for that. Let's go to the next slide, if you will. These are, again, responders in terms of the latest crisis news that we have available for you. Just to take a look at a couple of them. The podcast, Answering the Call, Part 3 would be one thing that you can certainly reference. Also on that same element is the Washington Post article on the LGBTQ youth, we'll call 988. They're interesting articles that you can certainly reference. The quote for today comes from Dr. Michael Hogan, who talks about the whole paradigm of thinking about suicidality has been wrong, which is suicidality is secondary to mental disorders. And so if we treat the mental illness, we take care of the suicidality, and we find out not so much. Great quote, because we are now determining that it is exactly the opposite way, that if we can do premonitory work and do some projective work, we definitively can reduce the elements of suicide. And next slide, please. And we are now ready for our feature presentation of today, and it's coming from the Colorado Crisis Hub, the Rocky Mountain Crisis Partners. And we have with us today Dr. Michael Allen, the Medical Director, and Bev Marquez, who is the CEO. And at this point, I'm going to turn it over to them.
All right, thank you so much, Dr. Sims. And it is such a pleasure to be here this morning with all of you, many of you who I have worked closely with over decades, so many of you that I respect your work so deeply, and hopefully many of you that I can meet in the future, hoping that you had a successful and celebratory 988 launch. I'd like to talk about, yes, next slide would be terrific. Rocky Mountain Crisis Partners has had the privilege of providing many programs in the crisis continuum in Colorado. Starting in 2011, we started answering the National Suicide Hotline for Colorado, and now the provider of 988. We were privileged to receive the award for the statewide hotline, peer support line, and text line in 2014. And that encompasses peer support services, online emotional support, which is our texting, and we also focus considerably on follow-up. Live Connect is a program where we are available to provide crisis lines for some of our other service partners. We are going to hone in more on our follow-up services today. Next slide, please. And this represents this is a visual for the different kinds of follow-up programs that we provide. Peer support follow-up on our support line, crisis follow-up for high-risk kinds of concerns when somebody calls our 844-493-8255 number. And we also have state opioid follow-up response. Today, we will be honing in on hospital follow-up to demonstrate a program that we are deeply committed to and have a lot of impact in Colorado and feedback from those that we serve. Next slide, please. I am at this point going to turn the presentation over to Dr. Michael Allen, who will give his own introduction. And we are really honored that Dr. Allen serves as our medical director.
Thanks, Bev. It's been a pleasure to work at originally Metro Crisis Services, now Rocky Mountain Crisis Partners, Low these many years. The program we're going to be talking about today is really one of going from evidence to feasibility to scalability as we went from research to application. We've known for a long time that transitions in care are particularly fraught and that most of the people who die by suicide will do so in the week or two after being in the hospital. So we need to be particularly mindful of that population. Next slide. We also know that people who visit the emergency department are at very high risk. This is from some of my own work with Ed Boudreau at UMass. We looked at people with active suicidal ideation in 8 emergency departments and found that they had 4.65 out of 6 warning signs or risk factors, and 72% had made a prior attempt. Of the patients we looked at, only 3 had no warning signs or risk factors. So everyone looked risky, and 10% went on to make an attempt within 6 weeks, even though more than half of them were hospitalized. So we know that people coming out of the hospital and people seen in the emergency room are risky. We also know that about half of patients never attend their outpatient appointments. So if they receive no mental health care at all during the first month, and that's the highest risk period. We also know that repeated caring contacts after discharge can mitigate that risk. Next. So we began to focus on this in the ED SAFE study. We first started screening alone and found that screening was ineffective. Merely identifying people at risk did not improve their outcomes. But when we implemented a telephonic outreach program, we were able to achieve a 30% reduction in their risk. This was published in 2017. Now, we knew even before that finding became available that this was a promising service. And so we began to test it in Colorado with a pilot program that we've previously published. Next slide. At this point, I'm going to turn it over to Eric Jacobson, who actually makes these calls and can really convey how they work and why we think this is going to be beneficial to people. The thing that we did in ED SAFE was a very manualized kind of treatment, but what we've done in Colorado was designed to be more pragmatic and scalable, and Eric will tell you about that.
Thank you, Dr. Allen. My name's Eric Jacobson, and I'm the Community Program Liaison at Rocky Mountain Crisis Partners. And my responsibilities include supporting many areas of our follow-up program operationally. Now, we've established the importance and value of a follow-up call as an intervention. I want to take a moment to talk about what we actually do on a follow-up call. Now, some of the nuance with a follow-up call is that it's at a pre-established time and that we initiate it. However, when a person on the other end of the line picks up, our primary responsibility is very similar to that of a crisis call. Meet the caller exactly where they are at. Now, what does this look like? Well, hi, my name's Eric from the follow-up program. I'd like to speak with so-and-so. How are you doing today? Depending on the answer to this very basic question, the call can take many forms. That person could say something to the effect of, oh, I'm actually doing much better. You know, I was in the hospital a couple weeks ago and, you know, I've got an appointment scheduled on Tuesday. I'm doing X, Y, and Z. And what is our responsibility? It's to meet them exactly where they're at in their progression of recovery. And so what we could actually do on that call is help connect them with resources, identify barriers to care, and then at some point, and we do this on absolutely every call, but we ask them about thoughts of suicide. It's absolutely critical for us to understand, you know, where this person is, irregardless of how they are presenting that day. Now, certainly, when we initiate a follow-up call, that person could pick up the phone and they could be in crisis. And we will meet them exactly where they are at. We will use our skills and our toolbox to help try to support them in that moment and stabilize the situation, much like we would on a crisis call. Next slide, please. I do want to take a moment to illuminate the scale in which we are operating. And this data is from the first 6 months of 2022. We served 3,559 people, 47% of which were under the age of 24. And it seems to be a growing trend that more young people are coming into our emergency departments with established mental health concerns. And 101 of those 3,559 were under the age of 9, which to me is just staggering. 57 identified as veterans, and in total, we completed 20,410 follow-up calls, as defined by an attempted outreach, a successful outreach, or a voicemail left. Now, all of the calls within our hospital follow-up program occur between the hours of 8 a.m. and 10 p.m. But keep in mind, the grander scope of our follow-up program functions in a 24/7 capacity. Because our crisis line is 24/7, we could get a call at 2 a.m. in the morning, and perhaps that caller is at high risk. And as part of our safety plan, we want to schedule a follow-up call 2 hours from now. We need to have the infrastructure to have someone call them at 4 a.m. And that's something we do. All of our crisis specialists are trained in how to perform an outgoing follow-up call. And it's really part of our operation that never stops. Next slide, please. This is my favorite slide. And as Dr. Allen mentioned, you know, this really speaks to our scalability here. Here we have a map of Colorado, and what these purple blobs represent are hospitals within our state that we are partnered with as part of the hospital follow-up program. From the northeast corner of Colorado down to the southwest corner, that's approximately 500 miles. This is a massive piece of land. And within that, we're partnered with 69 facilities. And this is something I'm most proud of because I didn't know this prior to moving to Colorado, but Colorado is quite diverse geographically. And if you're speaking with somebody who lives on perhaps this eastern portion of the state in what we call the Eastern Plains, a much more rural agricultural community, life is much different than somebody that is living in downtown Denver. And that is much different than somebody living in a more rural mountain town such as Durango. And so this connects back to what I was talking about with meeting the caller exactly where they are at. I am so proud of our call takers and our call providers in their ability to establish rapport with such a diverse population. What we are doing in those first few minutes of a follow-up call is the most important piece. Establishing connection, establishing trust, trying to make that person feel safe. And we are able to do that with so many different types of people living in so many different parts of our state, with different views politically, with different views on this and that, but we always do that. And it's at the core of what we provide, which is human connection. And now I'm going to toss things back to Bev.
Thank you, Eric. So we have been providing hospital follow-up services in particular for approximately four years. And this is one of the easier lines of service that is to capture satisfaction data, the benefit of the call kind of data. And so since the beginning of the program, we have kept information about what are those that we engage with, what are they saying about the difference that follow-up calls made in their lives. And what you will see is that 4.5 out of 5 of folks that responded said that they really felt care in the communication with our follow-up team, which, as Eric said, is a key goal of ours. The other is, did this help you be motivated to follow through on your plans? And we rated at a 4.4 in that area. Were you feeling more hopeful as a result of being in the hospital follow-up program? And 4.3 was the rating in that area. And then are you more likely to reach out for help as a result of being engaged in this program, the score being 4.4? And do you feel an increased ability to stay safe, rating a 4 overall? Now, the N, as we can imagine, is a bit low in collecting that data, but we still believe that getting that kind of feedback about the impact of this program when we do connect and we can get data is exactly consistent with the objective and the care that we want to provide. We have been really blessed in Colorado that our Office of Behavioral Health Authority has really been willing to see the value of this service. And here is a slide of our funding partners, because it is not always something that is funded as part of the crisis line and incoming calls. And a special shout out to the Office of Suicide Prevention. And you're going to be hearing from Sarah Brummett here in a bit, because we started very small about getting funding, but it's taken a village of funders. It's the Office of Suicide Prevention, the hospital, the Colorado Hospital Association has partnered with us to encourage folks to connect with us at the point of discharge. And again, the Office of Behavioral Health and our Behavioral Health Administration have all given us funding. And I must say, huge shout out to Samsa, who has given us 3 years of funding to provide the different components of hospital follow-up. So between all the sources, we have a very comprehensive umbrella of staff and infrastructure and support that we can offer to this program. So thank you very much for the opportunity to talk about our follow-up program.
Well, thank you all for that phenomenal presentation. And my apologies go out to Eric because I didn't include him in there, but he was such an important part of the trio there. I didn't want to go without saying to you, Eric, phenomenal in terms of what you guys are doing. A lot of wonderfully positive comments made in the chat box, but ones that resonated really talked about follow-up calls, communicating a we care, perhaps like nothing else that crisis care does. I got that from Dave, but Vic also put in follow-up creates connection at a different level. So kudos to you guys about all of those things. Just one question out of the box there. Can volunteers or non-clinician employees be trained as follow-up callers? And this would obviously be in addition to peers.
We currently have 100% paid staff model. And yes, definitely peers can also provide follow-up on the peer support line, but also one of our grants also covers peer specialists to be involved in following up on hospital calls as well.
Well, thank you, Bev. And in the interest of time, we're going to move forward with our roundtable discussion. We have 2 and possibly 3 on board. Sarah Brummett with the National Action Alliance and Preston Looper with Full Tilt Strategies. Do you guys want to take it for a few moments?
I'm happy to hop in. Thank you, Bev and Eric and Dr. Allen for that. I always love hearing about the follow-up project. It's something definitely near and dear to my heart. And I think something I wanted to underline, underscore, and highlight that Bev shared is really the collaborative nature of the project, that no one funding stream is sufficient to support a project like this. And I think Colorado has done a really excellent job at looking at all the different levers and opportunities to support this project. And kind of speaking to all of the different goals and objectives that different systems have, and really working to make this a standard of care across the state and hopefully eventually even farther. That no matter where I live, I want to know if I'm leaving the emergency department after a mental or behavioral health crisis, that someone will follow up with me to make sure I'm okay and make sure I have what I need and help navigate through that process. I really do believe that that is foundational. And I think the last thing I'll just share before turning it over to Preston is this project wouldn't have been possible without the existing infrastructure that Rocky Mountain Crisis Partners had, with serving the National Suicide Prevention Lifeline, serving the Colorado crisis system, and the investment that Colorado made in crisis care. So really just wanted to underscore that was absolutely essential, is having that foundation. And I hope that other states will now have that with the expansion of 988 and all of the investments that the nation is making towards that.
Hey, thanks, Sarah. Inspiring presentation, Rocky Mountain Crisis Partners. That was phenomenal. It's very cool to see follow-up highlighted as a core service, as opposed to a necessary evil, if you will. I think sometimes it can be, just something that people are doing in terms of going through the motions. And I think it's very cool to hear how y'all are combining evidence and customized experience for the individual. That was very cool to see. The other thing that I really want to point out is the slide that showed how many unique persons served and the number of outbound calls that were made. That was very clear that there's a high level of persistence from this operation to reach out to people and provide care. And that was really great to see.
Thank you. And again, I want to thank everyone. Thank you guys for that roundtable portion, but I also want to thank our three presenters, for an inspiring conversation in this regard, and we've taken a lot from it. But one of the things I really want to just leave folks with is just the emphasis on how critical it is on the follow-up care and how much that really does make a difference in there. So thank you all again for that wonderful presentation. Let's move to the next slide, if you will. And this is just a reminder slide for everyone that if you would like a wonderful t-shirt like this, it is open to you. You can do it in several ways. One way is to go to the next portion, which is you can be on our hot seat. Otherwise, you can purchase it, and Karen will put all of the information into the chat box for everyone so that you're able to get it. I see that some people have actually purchased a few already. That is phenomenal. So moving ahead, we're going to go to the hot seat for today. And I'm looking online and I don't quite see our person who is going to be our crisis hot seat. So we'll have to talk to her about possibly getting a t-shirt at a later date. So what we're going to do is just poll the audience on this particular question. So I'll read it out to you and then we'll do a poll and we'll just get a feedback from everyone as to how it turned out. So Samsa's national guidelines for behavioral health crisis care included zero suicide and suicide safer care as one of their core principles, including evidence-based direct treatment for suicide risk. So the question that we have for you all, the Zero Suicide Institute identifies 3 evidence-based direct treatments for suicide risk. And of the 4 choices below, which of the following is not one of them? Is it DBT, CAMS care, standard outpatient mental health treatment, or cognitive therapy for suicidal patients? So if you would take time out and just put your answers in the box, we'll see how the audience does all together. We'll give that a moment to kind of populate. And I love the comment. It is indeed, we are questioning the power of the people, because if we look at the responses, nearly 70% of you say it's standard outpatient mental health treatment. Let's go ahead and take a look at the answer. And it is, as you have pointed out, we have a wonderful audience there. I wish I could say that all of you would get t-shirts, but I think I would get in a lot of trouble if I did say that. But just congratulations to you if you got it correct. We will definitely be looking for a nice audience participation possibly in the future, but thank you so much for being a part of that so we can then move ahead, and congratulations. Next slide, please. We've now made it to our data corner, and I'm going to ask at this time for Jonathan Cantor if he'll come forward and speak first, and I believe he's going to hand off from there. So Jonathan, go right ahead, sir.
Thanks. Good morning to you on the West Coast and East Coast. Good afternoon. I'm John Cantor. I'm with the RAND Corporation, and I'm happy to be able to discuss some work that we did prior to the rollout of 988. This is with co-authors who are all from the RAND Corporation as well. So what we did was we administered a survey to about 180 state or county behavioral health directors between February and March 2022. And from estimates, we predict that they serve around 120 million Americans in the US. We found that it was pretty easy to identify state behavioral health directors. We found it was relatively challenging to identify county or local behavioral health directors. And ultimately, we had a response rate of about 26% of everyone that we emailed or to request to take the survey. The survey had 4 key domains: strategic planning, financing, infrastructure, which also included staffing, and service coordination. Of those 180, we did more detailed, in-depth qualitative interviews with 15 directors that were either more prepared or less prepared for the rollout of 988. And again, I want to highlight the fact that these results all occurred prior to the rollout. So, you know, I think if we did the actual survey again more recently, we'd get much different results potentially. Next slide, please. So I'm just going to give you a quick rundown of the findings. And if you need to actually identify the report, feel free to email me offline and I can direct you to it. So as a highlight that a positive result that we'd like to highlight in terms of strategic planning, 97% of the respondents thought that preparedness for the rollout of 988 was somewhat or very important. Slightly more concerning was that we found that about fewer than half were involved in the development of a strategic plan. In terms of financing, we found only about 1 in 7 of our respondents said they had established a long-term budget for the support of 988. In terms of infrastructure, we found that 85% of the respondents said that their communities currently have a crisis hotline of some sort. Another result I try to highlight as well is that more than half of our respondents reported that they either have clinical personnel available 24/7 every day, or that they had employees that received applied suicide intervention services training. In terms of service coordination, we were a little bit more concerned about the fact that about half of our respondents collected information on time to answer, and that fewer than half did on dropped abandoned calls or whether callers and emergencies are connected to mental health services. Mostly asked about this also for if we intend to do an evaluation of 988, these are some sort of the data components that we really want to see collected in order to actually get a full picture of how things are going. And then the last bullet is for about our qualitative interviews. We found that the biggest limitations for the rollout were that there were persistent mental health workforce shortages and retention issues. We heard about burnout a lot in terms of workforce. We also found that lack of funding and a request for more coordinated planning. The primary strengths were that a lot of this led to and the ability to get providers with solid local knowledge. Again, I want to highlight the fact that these results were earlier in the year prior to the rollout, and that we hope folks are going to be doing continued evaluations of how things are going. Because we all want this to work out well. Next slide. Thanks.
Okay, Matthew, you were going to make a comment, sir?
Yeah, thank you. And thank you so much, Jonathan, for presenting the RAND report. I think a lot of people saw that the RAND report was referenced in various news articles. I think is a good example of using the research methods, surveys, interviews to really understand what's happening out in the world and inform further development of policy. We've got lots more policy decisions in our future, as 988 was just the first step of this long journey towards expanding crisis service continuum. And so I think the RAND report really highlights an approach to using data and research methods to do that. Just briefly, in terms of our Data Corner Bytes for this month, I included a publication by Jonathan Pirtle and colleagues in psychiatric services, where they did an analysis of the National Suicide Prevention Lifeline's in-state answering rates, stratified by call volumes and geographic region. And what they did was they wanted to understand if there was any relationship between the volume of calls that each state gets and the answer rates within each state. And so answer rates range quite broadly from 10% to 98%, and the average in-state answer rate was 71%. And the number of calls per 1,000 people, per 1,000 residents in each state also ranged quite a bit. And so the question was, does more calls mean that that's what's taxing answering rates and makes answering rates lower? And they found that the answer was no. There was not a relationship that they found in their analysis between answer rates and call volume, which suggests that it's not that really high call volumes are what makes it hard for states to be able to answer calls as much. It must be other factors. And so it highlights sort of future directions as we're anticipating increased call volumes, that additional work is needed to done to really understand what's impacting answering rates in states other than call volumes. So I'll share the link to that article here in the chat and appreciate your all's time for this week's Data Corner.
Well, thank you both for that information. We're certainly looking forward to further information on that. If we move to the next slide, we're into the crisis talk portion of Connecticut Statewide Youth Mobile Crisis Service. And we have Tim Marshall to just give us a minute or so on that.
Good afternoon. Thanks for inviting me. Appreciate this and appreciate the highlight of Connecticut. Just a couple of points. One is, I think really we were trying to highlight the difference between children and adults, particularly in the mobile crisis arena. Connecticut made the decision that we were going to purchase the best practice of purchasing face-to-face assessments, that we don't triage telephonically or using telehealth. So that's probably the main point there. A little bit of an apology out to school personnel and parents and caregivers, the way I was referenced in the article, unintended, a little bit less than strength-based, because parents and caregivers, their information about when they call on children in their care is very important. The point I was trying to highlight there is that the main point is that most children are not calling. It's an adult, most commonly school and staff, and that we are purchasing the face-to-face assessment. Before when we were still based on mobile over 10 years ago, the assessment process was showing that less than 50% of the time for our statewide average, and some providers as low as 25% were going out face-to-face, which was causing school personnel and parents to kind of try to say anything in order to get the mobile team to kind of come out, if you will, and assess. So we switched over and we purchased the face-to-face assessment. It's our priority. We also wanted to purchase a fast assessment, so our benchmark is within 45 minutes. I know Connecticut is a small state, but many counties are about our size or smaller. So, and we have kind of a two-part system. We have the stabilization of the acute crisis, and then we do have up to 45 days of follow-up and linkage to ongoing services. Our main benchmark is this notion that 9 out of 10 calls must be mobile, and that 10% has really worked pretty well to be inclusive of family members, parents, caregivers who are unable to be available when the call comes in. So I think those are our big high points, and just continue to work on our model here in Connecticut, and the information that we're getting on Crisis Jam and others areas has been fabulous. So just really appreciate it.
Well, thank you again, Tim, for that. And I'll just refer you to the chat box. Karen has put in that particular site service for your information. And as we move forward, we're now ready for our Samsa update. And I believe we have John Palmieri with us today. Go ahead, John.
Thanks. Hello, everyone. Good to see you all. And yeah, just going to provide a quick update from Samsa. I don't think Richard McKeon is on the call today. He's traveling. But we, of course, the big news is the transition that occurred on July 16th to the 988 Suicide and Crisis Lifeline. That was a successful transition, and you will see we will be coming out with, I think there was some questions in the chat about volume and data and that sort of thing, and we will be coming out with some more detailed information about how the network is doing, but you will certainly see that there have been significant increases in volume for the Lifeline, and many more contacts that have been addressed from people in crisis, even compared to the week prior to the transition. So we see all of this as very encouraging signs, both in terms of help-seeking behavior and the fact that the network is serving and helping more people. I also just wanted to take a moment to thank all of you for your efforts in making this transition successful, and also especially the Crisis Center staff and organizations who have really stepped up, and Vibrant Emotional Health as well, really stepped up for this transformative moment. Extremely appreciative of all your work. As somebody mentioned, you know, there's been, and I'm sure it's apparent to all of you, lots of media coverage, including celebrities, influencers, a lot of press related to 988. And we see that as a very positive sign, again, about spreading the word about the importance of this life-saving service. It also reminds us that it is important to make sure that our messaging is aligned and coordinated. And in that spirit, a couple of reminders to continue to consult our partner Toolkit. There are end cards there that we encourage you to use as much as possible so that they can get updated across media. We have updated our FAQs. We'll continue to do that in part based upon what we're seeing in terms of coverage or misunderstandings about the Lifeline. And so that will continue to be a work in progress, but we have updated them recently, as well as an email newsletter in the partner toolkit. And then wanted to thank everybody for all your efforts in sharing our social media and digital shareables. And again, more work to come in all of these areas. I think that's it for me.
All right, well, thank you, John. And first and foremost, thank you for the incredible amount of work that you've been doing in this whole process, and to Samsa and their tremendous leadership in this initiative in terms of implementation. Really looking forward to what's coming ahead, and thank you for that positive information that we can share with everyone. If we move to the next slide, we are now ready for our NASPID updates, and Dr. Hepburn.
Thank you, Dr. Sims. Just wanted to thank Wendy for her kind words regarding Sharon. NASPID has lost a friend. Sharon made many contributions, and in some of those, she worked very closely with NASPID. She will be remembered fondly, and she will be missed. So thank you very much, Wendy. Also want to thank David Covington and his team, Karen Jones, Ren Koenig, and others for the Learning Collaborative. This is impressive. Every week we get together, and it's really a learning opportunity. We thank you for all the work that you do in setting this up. And we know that the success of 988 is partly related to the work that's done through this collaborative. So thank you. And as John said, this has been a big week for the country, also for the states. The states are reporting, as John indicated, an increase in volume, but also that they've been able to keep up with very good answering rates, even though it has been an increase in volume. Want to thank Samsa for their leadership, Dr. Miriam Delphin-Rittman, John Palmieri, Anita Everett. Also a special shout out to Richard McKeon. I don't think he's on the call, but Richard is somebody who's been a champion of suicide prevention, crisis services, and then 988. He has a long career of putting his heart and soul into this work. So thank you to Richard. And thank you to all of you. This is a real change in the system, and an opportunity for us going forward to really have a better system for individuals who need our services. So thank you very much. And back to you, Brian.
All right, thank you, Brian. And thank you for all that you do personally. Let's move to the next slide, please. And as far as the current updates, we've been informed that not a lot is going on in the Hill, so a request has been made that we may forego these until at least after Labor Day, when it is expected at that point that there'll be more updated information available for everyone. So let's move to the next slide, please. And with these, I'm going to call on Jordan. If you have a few comments you want to make on this.
Yeah, thank you, Brian. Kind of quiet on the state front as well. I'll just say one quick thing before I turn it over to Steph from NAMI. Just in California, their 988 bill, AB 988, is being heard in the State Appropriations Committee on August 1st. So hopefully we'll have an update in a couple of weeks. I will turn it over to Steph for one more quick update.
Thanks, Jordan. Definitely very exciting to see such a comprehensive implementation bill like California's AB 988 moving forward. Just one other quick legislative update I wanted to give is from Alaska. House Bill 172 was signed by the governor, and this clarifies the process for diverting folks that are in crisis to various crisis stabilization options instead of law enforcement involvement. And this is part of the state's larger effort to implement the Crisis Now model. And that really wraps it up on the state front.
Well, thank you. Thank you, Steph, and thank you for that. Let's move ahead on to our next slide, please. And these are our state stack cards. If there's any of the state representatives that would like to maybe comment on these, this is an ever-growing element that shows that they're implementing in their legislation, particularly 988 language. So if there's anyone from Washington State or otherwise that would like to just say a word or two on it, that would be wonderful. or Nevada, Utah. If not, what we're seeing is that this, like everything else, is beginning to come across in a very positive way. There are many states that are now asking about that particular Medicaid expansion component. And you can see from these slides that many of the states are implementing that into their baseline. So let's go to the next slide, please. And at this point, with the tools component, I'm going to call on Paul. Paul, if you would address this, please.
Happy to, Brian, and thanks a bunch. What a great session it's been today, and I love the focus on follow-up calls. I was meeting with Kana Inamoto's team at McKinsey & Company earlier this week, and we see hundreds of people continue to use the calculator each month. So just as a reminder, I'll post this quickly. You can find it on its website, calculator.crisisnow.com. And when you get in there and use it, one of the things that I haven't seen done a lot is still the adding modified scenarios. So you do have an option when you click in there, Brian, to not only look at what the projections are and editable for your state on what volume you might need for mobile response teams, crisis receiving center chairs, short-term crisis beds, and what those things might cost and your impact. But in fact, you can actually go in and you can say, right now, what we're focused on is we're doing our 988 system, and we're focused on the mobile response teams, and we're looking at how we can add some receiving center chairs. If you want to do that, you can create what's called a modified response on the left-hand column of this tool. And when you go in there, it will give you projections of the impact you would have based on just doing those things as opposed to focusing on the whole continuum at this point. And of course, it can assist states, counties in their planning process. So one of the things I'd encourage some of you to do, if you're looking at a phased in approach to how you would develop your crisis system, is think about modified scenarios, look in there and get some of that data and let that inform what each step might look like, what it might cost, and what the impact of each could be. So it's a really fantastic feature that McKinsey & Company's team put in there.
And again, Paul, if you want to just say a word or two again about specifically how to connect, because I'm an old guy now. I get it the first time, but I usually have to hear it a second time for it to kind of sink in. So would you mind if you would go back through the links and how you would do the calculations?
Yeah, and I don't know if Karen, if there's a rule that I'm allowed to share my screen quickly, but that would allow me to do a few of those clicks for you, Brian.
Okay.
Let's see if we can do that. So if I share my screen here, what you do is you go into the calculator's homepage that you have and you say use calculator. And once you go in, we can do any state that we want. Let's say we're going into Nevada to do that. And of course, we can do this county by county, or we can do the whole state. And if you recall, Brian, what we have is without a crisis system, our projection of what this would cost an inpatient and emergency room care. And what we see if you did a full crisis system. And we have projections which can all be assessed as this is what the average cost of an inpatient bed is when we look at the commercial and Medicare payment in Nevada. You could alter this if you have Medicaid data that says it looks a bit different for you. You can change your lengths of stay, but this is data that McKinsey & Company gathered for your specific region. You can now go through, as you see, and you have projections on how many mobile teams might benefit you, receiving center chairs, short-term beds, all show up there. But we have the opportunity at this point to also create what we call modified scenarios. So if I say add a modified scenario here, and what I say is we are only going to do mobile teams at this point and crisis receiving center chairs. We're not going to do the short-term beds. You can see this middle column has been created on the right, which says 443 million. That's to say what those services might cost you based on the projections and the data that's been put in. And you'll see it actually says then in this case, this is how many inpatient beds we think you're going to need in that scenario as opposed to a full continuum. This is all not only reportable, but you can print it out quickly with a PDF. But the clicks are pretty straightforward. Go into add a modified scenario. You can play with and adjust any variable however you want to at this point. You're going to have specific data that tells you, again, this data for cost is based on Medicare and commercial payment. But you may say Medicaid is driving it for our state, and that number is a bit different. So you change your length of stay, you could change your costing, and it will give you really pretty solid projections to start moving this work forward.
Wow. And Paul, this is really great. What I love about it is the individuality, because it parallels so much with what we're doing in 988, is that the states have the opportunity to kind of take a look at their own selves and how their performance actually is. So this is great. I was wondering though, since we have a couple of minutes, if we have any representatives from NAMI or even from Vibrant, and get some feedback on your thoughts about this tracking and moving forward. So do we have anyone from NAMI or from Vibrant that would like to just make a comment? Just come off of mute, please.
Hi, Brian. This is Laura Evans from Vibrant. Hi, good to see you. Great job hosting as always. And I just wanted to say on behalf of Vibrant, we are so thankful for all of the support from our local crisis centers, over 200 in the network. We would not be a network without your hard work. So we are so grateful for the centers and the crisis counselors answering calls, chats, and texts. So grateful for the leadership from Samsa and HHS. As mentioned from Dr. Hepburn, Richard McKeon, who isn't here, has just been such a driver for this for so many years. And so to see this come to fruition and kind of really start to change the conversation of how we treat crisis situations in the country is amazing to see. David Covington, Nashbit, you all are just key parts in ensuring that we're sharing best practices and continuing to advance the field. So I just want to say thank you to everyone on the call, to my advocacy counterparts at NAMI, Mental Health America, Centerstone. This is a team effort, and I am just so grateful to be in this with all of you.
Laura, we can't say enough times about Vibrant and its wonderful involvement and just the energy that you bring to it. Thank you so much for what you do and what you also bring to what is happening here. Do we have someone from NAMI that would like to just make a brief comment?
Sure, Brian, this is Stephanie. I think Laura really said it all. I mean, none of us could do this alone. So it's just been such an amazing community here, hosted every week. And really, it was so heartening over the weekend to see such a flood of positive news all about 988. And I do want to acknowledge some of the chat in the chat box about there is some, misunderstandings about 988 cropping up, but, I know that was the sort of overwhelming minority of the communications that I've seen thus far, but we are looking at also how to get out in front of that and definitely lead with fact-based information about 988. So I'm glad that people are flagging that as well.
Great, Steph. Thank you so much for that. We're coming across the end of our time, but before we go, I was going to call on Dr. Hepburn, if you would, to just make a few comments on the upcoming annual meeting. That's if he is here. I don't, let's see. All righty, well, we'll move ahead then. And this slide here is just a reminder actually of this trailer, Moving America's Soul on Suicide. It actually took place last week, but it's a reminder again about the power that comes from these messagings in this particular trailer, keeps it at the top of our forefront of our thinking. And lastly, what we'll do is I want you to take a look at the upcoming events, because as you've seen, we've had a very star-studded, if you would, element of those who have been spoken before us, but we've got some wonderful things coming up next week. Gabriella Wong speaking on making emergency help accessible to all. Looking forward to that. And as you look ahead, there are a number of incredible topic areas that are going to be discussed. I shamefully want to point out one that particularly of interest with the smart anti-racism tool created by Dr. Rachel Talley and her associates. Be a good time to also connect during those particular times. And also want to point out the fact that we've always had international representation in this crisis jam element. And coming up, the UK's 111 for mental health. Be very interesting to take a look at. So with that, I appreciate all of the comments, all of the chats that have been placed into the box here. I say to everyone, welcome into the 988 soft launch and implementation. An incredible group of folks and incredible timing. So I've been thrilled with being the host for today, and we look forward to having you all come on board next week. So with that, have a wonderful week, and I'll see you then.